Bismillahirrahmanirrahim. Dear colleagues, welcome back. In this session, let's address the most critical question: which patients should receive resmetirom? We know fatty liver is widespread, but resmetirom is not meant for simple steatosis or mild MASH. The right candidates are those with biopsy-proven MASH and fibrosis stage 2 or 3, those with a risk of progression to cirrhosis. Look for patients with metabolic syndrome features, obesity, type 2 diabetes, dyslipidemia, and assess fibrosis using FIB4, transient elastography, or MRE. A non-invasive risk stratification approach can guide referrals for liver biopsy or therapy initiation. We shall focus on identifying those with progressive disease who are most likely to benefit, ensuring this novel therapy is used judiciously and effectively. Using resmetirom in the right subgroup is crucial to avoid overtreatment and ensure value-based care. Bismillahirrahmanirrahim. We are discussing resmetirom, the recently approved drug by DRAP in Pakistan, and it's a very affording price. And as we have got huge number of fatty liver disease patients in our Pakistan, that's the reason I wanted to share with you essentials aspects of this drug to help you in prescribing the drug to the right people in the right dose in the right duration. So today, this is the second vlog on this topic, and I'll be sharing with you the resmetirom therapeutic opportunity for MASH. MASH remained a disease with significant unmet need and no approved therapies till now. We know that. Resmetirom is a liver-directed oral thyroxine hormone receptor beta agonist therapy targeting the underlying causes of MASH. The unprecedented phase 3 results, first therapy to achieve MASH resolution and fibrosis improvement endpoints. We saw that and we discussed that in the last vlog. We know that MASH increases the risk of cirrhosis, liver failure, liver cancer, and premature mortality. Risk of liver-related mortality increases substantially once significant fibrosis develops. And there's incidence of associated HCC expected to double between 2015 and 2030. 22% of the patients with stage 3 fibrosis progress to cirrhosis within 2 years. This is the progression over from F0 to F1. And when the patient comes to F2, then there is a very exponential increase, and the patient entering into F3. It's going to be a leading cause of liver transplants in the United States for women soon to be over. So this is the data from the US. The goal should be treat MASH with significant fibrosis prior to negative patient's outcome. So before that, the patient reaches F4, becomes cirrhotic, and then the subsequent complications of cirrhosis, including HCC. So to block that pathway, that progression, we need an effective therapy. This is the resmetirom position in the MASH treatment paradigm. When there is no or mild fibrosis, it means fibrosis stage is F0 or F1. The percent of NASH patients by 2030 will be 10 to 15% with the F0, those patients who are having fatty liver disease, and 30 to 35% will be F1. And the primary treatment goal should have been to manage cardiometabolic risk. So the disease starts and initially there is a cardiometabolic risk. So when there is no or mild fibrosis, you need to, the primary endpoint is to manage cardiometabolic risk. And the potential treatment for this stage is lifestyle changes in GLP-1. So these are the treatment modalities. Once there is significant fibrosis, that is F2 and F3, and the F2 fibrosis will be then 20 to 25%, and F3 will be 15 to 20%. So the primary treatment goal here is to halt or improve fibrosis and resolve NASH. And this is the group where there's a role for resmetirom, and this was the results were shown by the Maestro NASH. So this trial has shown that this is the group of patients where we need to intervene. And once the patient develops cirrhosis, that is F4C fibrosis compensated and F4D decompensated, 10 to 15% of the patients will be in this and less than 5% here. Then the primary treatment goal will be prevent liver failure, HCC, and need for transplant, and death is the answer. So the studies are already going on, and outcomes trial in F4C will probably answer us this question whether resmetirom can be helpful here or not. And of course, the liver transplant is the only option for decompensated liver cirrhosis because of the MASH. So the most advanced and comprehensive clinical development program, the Maestro Phase 3 program, the Maestro MASH significant fibrosis, it evaluates NASH resolution and or fibrosis improvement on liver biopsy in complete clinical outcomes. It's a 52 weeks biopsy-proven case completed, and 54 months clinical outcomes will be assessed. Then another phase 3 trial is that of the Maestro NAFLD-1 safety, where it evaluates safety and tolerability as measured by incidence of adverse events. It's again a 52 weeks trial, and it is completed. And the third is the Maestro NASH outcomes, that is in the compensated cirrhosis events-driven trial evaluating progression to hepatic decompensation, and currently it is in the 36 months. So this is the Stephen Harrison, Dr. Stephen Harrison. He's the main behind all this phase 3 Maestro clinical program trial. And I've already shared in the last vlog with you the Maestro MASH protocol, then the Maestro NAFLD-1 and the Maestro NAFLD OLE protocol, and then the of course the Maestro NASH outcomes protocol. I have already discussed this with you in the last vlog. So this is the 4 phase 3 trials components of this program, and this is going to tell us what is the role of total complete role of resmetirom in the fatty liver disease. The Primary endpoints of the Maestro NASH trial, we discussed in the last vlog as well. Once again, in the NASH resolution as the primary endpoint, in the placebo group, it was 10% response was found. In the resmetirom 80 milligram, 26% was found, and in the resmetirom 100 milligram, 30% response was endpoint was achieved. The second endpoint, the primary endpoint, the second component, this was the first part of the primary endpoint. This was the second part, the more than 1% stage fibrosis improvement. In placebo, 14%. In resmetirom, 80 milligram, 24%, and in 100 milligram, 26%. And the secondary endpoint, that was the LDL cholesterol drop. It was only found in the resmetirom group, in 80 milligram, 14%, and in the 100 milligram, 16%. So, and we know that we'll be seeing this in the coming vlogs, that when the weight is less than 100 kg, you give them the 80 milligram. It is more 100 kg or more, you give that patient the 100 milligram. So this was very much favorable emerging safety and tolerability profile for resmetirom, and I discussed this in detail in the last vlog. So once again, how should we apply the results of this trial to our patients in everyday clinical practice? First is identify patient at risk. And who are those patients? Those who are obese, who are having type 2 diabetes, who are having fatty liver disease on ultrasound, or who are having first degree relative with MASH related liver cirrhosis. So anyone, not necessarily that patient should be having all these 4 factors. Any risk factor, if the patient has got, either patient is obese, or if the patient is type 2 diabetes, or if the patient has got fatty liver disease, or if the patient has got first degree relative, then this is the patient at high risk. And what you do in these patients, you check for the FIB4. If it is less than 1.3, you label that as the green group. When it's between 1.3 to 2.67, he is in the yellow group, the signal lightning. And if it is more than 2.67, the value of the FIB4, he is in the red group. So in the green group, resmetirom is not indicated. And if the FIB4 value is more than 2.67, resmetirom is now indicated in this group of patients. If the results are in between, then you do the fibroscan elastography. If it is less than 8, again, this patient does not need resmetirom. If the patient has got more than 8, this patient needs resmetirom. Remember, the green is not always green. You need to follow up these patients. So I end here. Thank you very much for being with me. And I'm trying to discuss the different aspects of the resmetirom, so we are able to use it judiciously in our patients, and in a proper way to prescribe to those who need it. We don't over-prescribe it, and we don't under-prescribe it. So inshallah, in the next vlog, we will be seeing other aspects of this resmetirom and to understand it in more depth. Till then, take care. Khuda Hafiz.